All right. Hi, everyone. Thank you so much for coming out on for today's webinar. We're going to get started in just a moment as people continue to come in, but my name is Michaela Jackson, for those of you who might not know me, and I'm the Program Director of Prevention Policy at the Hepatitis B Foundation, and we're really happy to be collaborating with the Pennsylvania State Health Department on this webinar. So welcome, and we'll get started in just a second. All right. So today's webinar is going to be about hepatitis B, specifically in Pennsylvania, but we're also going to kick it off with just a little bit of a national scope of what's going on in the hepatitis B space so that you guys are all aware and can put things into a little bit of context as you go forth and do your work in the hepatitis B space. And before we kick it off, I do want to get started with just a few little housekeeping notes for you all in participation. Everybody is muted since this is a webinar, but we will have an opportunity for questions towards the end. There is a Q&A box at the bottom of your screen. So if you have a question pop up while somebody's presenting, feel free to put it in there or put a question in the chat and we will be sure to get to you. And if you just have any comments, please also feel free to drop those in the chat as well. And so with that, I'm going to turn it over quickly to my colleague, Catherine Freeland.
Thanks so much, Michaela, for the introduction. Hi, everyone. My name is Catherine Freeland. I'm the Associate Director of Public Health Research at the Hepatitis B Foundation, and I'm proud to just share a little bit about the foundation since we are based in Pennsylvania, and we just want to make sure people are aware of the resources that our organization can provide to you specifically for this webinar around vaccination awareness and outreach. But the foundation has been around since the early 90s, and we provide outreach and education, public health research, really centering around the lived experience associated with hepatitis B. We work on policy and advocacy as well, now really focused on policy efforts related to immunization access. And we also do education and training from provider CME training to community-based training or public health-focused training to raise awareness and raise the profile of hepatitis B in our work. We do have a research arm, and we're an organization that's dedicated to finding a cure and improving the quality of life for those affected by hepatitis B, and serving as a primary source of information for clinicians, researchers, and those with lived experience and their caregivers. You can view our website. I'll put it in the chat if you would like to access more information, and I'll also reference direct resources related to hepatitis B vaccine in the chat as well. Next slide, please. One of our programs that's based in the Philadelphia metro region is Hep B United Philadelphia, which is a local coalition that's led by the Hepatitis B Foundation. We're made up of over 70 community-based coalition partners, which includes the Department of Public Health, university health systems, social service providers, and community-based organizations that really served communities that might be at risk for hepatitis B. And we go out and provide free screening, education, and outreach, provider education, and advocacy efforts in the region. If you're interested in working with us or learning more, I'll also put a link in the chat, or you can visit the QR code linked on this slide. And with that, I will pass it back over to Michaela and put in resources and links in the chat in just a couple of minutes. Thanks so much.
Thanks, Catherine. So we just wanted to kick it off with that brief overview of the foundation, since I'm sure many of you are way more familiar with the State Health Department than you guys are about us. So we'll just get the webinar started now. About hepatitis B, it's a blood-borne virus that attacks the liver. It's the leading cause of liver cancer in the world. In the United States, however, about 2.4 million people are living with hepatitis B. In the world, it's around almost 300 million individuals living with it. So it's a pretty significant issue, especially with the fact that many people actually have no idea that they're living with the virus due to the fact that it often has no symptoms until it progresses to a much later stage. often cirrhosis or potentially liver cancer. So just 25% of people in the United States have actually been diagnosed. Lauren will go into a little bit of detail later about what's happening specifically on the ground in Pennsylvania. Transmission-wise, there's a lot of misinformation about how it is spread. Most commonly, it is spread mother to child during childbirth, as it is a blood-borne virus, but it can also be spread through unprotected sex or unsterile needles and medical equipment, which we often see on a global scale happening as well. If a child is born to a mother with hepatitis B, or if a baby or infant happens to be exposed to the virus while they are young, they have a 90% chance of going on to develop a chronic version of hepatitis B instead of acute. So it's really important that we're paying attention to vaccination to adults, but also to the babies and infants as well. The virus is 100 times, up to 100 times more infectious than HIV and can also survive on surfaces for up to 7 days if they are not properly cleaned. And anybody can get the virus. I think that's one of the most important messages that we can take away today. There's a lot of misinformation and misconceptions about who's at risk, and I'll go into it a little bit more later. But the fact is that anybody can get the virus. There's always some amount of risk for hepatitis B. So as I mentioned, hepatitis B is the world's leading cause of liver cancer globally. Nearly 80% of cases, liver cancer cases, are caused by hepatitis B alone. And we have seen increases in liver cancer, and death rates from liver cancer increase up substantially in recent years in the United States. There are some disparities within the liver cancer space in the US. So Asian Americans and Black Americans that are living with hepatitis B are often 11 to 17 times, have a higher risk, 11 to 17 times for liver cancer than other groups. And it's very costly to the United States, additionally, to have liver cancer when we can prevent it through vaccination and through proper screening methods. So just wanted to highlight that. So who's at risk for hepatitis B in the United States? Asian Americans and Pacific Islanders comprise less than 6% of all of the US population, but are responsible for over 60% of all chronic hepatitis B cases in the country. So that's a very big health disparity that we need to address. African immigrant communities also see large amounts of hepatitis B, and as you saw, additionally, liver cancer rates as well in the United States. But we also see smaller groups, so people who inject drugs, people with HIV and hepatitis C, people living with kidney disease and or diabetes also have risks for hepatitis B. So that's kind of what I meant earlier when I was talking about how anybody can be at some degree of risk for hepatitis B. It's not just one person. The risk factors for hepatitis B kind of span across the entire lifespan. From when you're a child, you have risk factors, to when you're an adult, you can have risk factors just simply due to other health conditions, for example. So we really want to make sure that we're addressing it where we can. So as some of you guys might be aware, we had two new recommendations come out from the CDC in 2022 and 2023 regarding hepatitis B, specifically in the adult space. So for universal adult hepatitis B vaccination, it previously used to be risk-based, but CDC updated the recommendations to include all adults aged 19 to 59, adults 60 and older with risk factors. But the part that I would love to highlight here is that they also stated that anybody who wants to be vaccinated may be vaccinated. So what that language does is really turn the burden onto us here on this webinar, the public health workers, the providers, to make sure we're having conversations with people about hepatitis B vaccination and about hepatitis B screening, and encouraging them to get vaccinated and or screened if they're interested. And the reasoning for this is because risk-based really failed in the past. We were missing a lot of people who had risk factors. As you saw, one of the main risk factors can be sexual transmission. People were not disclosing their risks for hepatitis B because it can be a stigmatizing conversation. It can be incredibly uncomfortable, or sometimes you might not, have time for these conversations if you have other healthcare worries that you want to discuss with your provider as well. So now we have the opportunity us here in the public health space to really have these conversations with people and make sure that they're educated and can make well-informed decisions about their health, whether that's vaccination, testing, or both. And for the adult hepatitis B screening, we also saw that updated from risk-based to universal. So all adults 18 and older are now recommended to get screened at least once in their lifetime. I would note here that there is no upper age limit on this, like there was on the 1959 for vaccination. And this is now the triple panel hepatitis B test. So the hepatitis B test has a couple of different ones that providers can select from, which has made things very confusing in the past, especially if you weren't sure which was the right one for your patient. So now it is recommended that the triple panel, which is surface antibody, surface antigen, and core antigen is being used because that gives us a perspective of if somebody was ever exposed to hepatitis B, if somebody currently has an infection, or if somebody has recovered from an infection. So it gives us the best picture possible for where they stand with their hepatitis B status. And with that, I will pause and turn it over to Lauren to talk a little bit about Pennsylvania.
Thanks, Michaela. Can you hear me okay?
Yep.
All right. So as Michaela said, I'm Lauren Orkis. I lead viral hepatitis prevention and surveillance activities at the Pennsylvania Department of Health as an epi supervisor. Really excited to be here today and share some Pennsylvania specific data with you all. I'm going to be going through this in a bit of detail, and I'll be pointing to some published documents on online that might be helpful to go through after we get done here. If you have some more detailed questions, and feel free to reach out to me as well for questions. So next slide. So we're going to be covering acute chronic perinatal B surveillance data today and going over some conclusions. Next slide. So the data that I'm going to be talking about come from a surveillance report that really was a long time coming, but we're really proud that we were able to publish on the PADOH website these surveillance data 2013 to 2022. This is the first time we've ever been able to publish hepatitis surveillance data outside of a small report that was published over a decade ago related to Hep C. So Hep B data really have not been accessible at the state level to the granularity we'll talk about today. We, in this presentation and in the report, we did exclude Philadelphia data because Philadelphia Department of Public Health does such an excellent job of their own viral hepatitis surveillance and prevention activities and summarize their data at the link that's at the second bullet here. So I encourage all of you to explore that, and I'll put that in the chat here in a second as well. But excluding the Philly data allows us to get a broader picture of Pennsylvania minus Philadelphia, as the epidemiology is a little bit different. It helps us really focus in on areas of concern outside of Philly, and the resources that are devoted to this work at the Pennsylvania Department of Health fund activities outside of Philadelphia as well. So that's excluded some data. For our mapping purposes, we did exclude folks associated with correctional settings because we didn't want clustering inadvertently around correctional settings, but those cases were included in our general graphs and such that you'll see, but not on maps. We did try and improve our race ethnicity data here a bit. We'll talk about acute, chronic, and perinatal, well, acute and chronic race ethnicity data, not so much on the perinatal side, and you'll understand that here in a second why, but did try to match that with our immunization registry data to try and enhance race ethnicity data available. We also matched with the birth registry to help us understand exposures, mom to baby. And we have some rates available using some federal programs and their data. As the example, the American Community Survey is one that helps us with rates. And we'll be doing some comparisons also to some national data that's published on CDC's website. Next slide. All right, so starting with acute Hep B, the blue line here is showing Pennsylvania, the orange line showing the US. Luckily, outside of Philadelphia, our rates of acute Hep B are a bit lower than they are nationally. We did, though, see a little bit of an uptick through 2022 that's not seen nationally. So we are certainly interested in that. And all of this work and summarizing the surveillance data is really getting us to some next steps that have been a long time coming for us. So really diving into some of these reasons why we might be seeing some differences here is an important next step for us. Next slide. Some of that increase is due in part to those a bit of a younger age, the 20 to 64-year-old group. You see that increase into 2022, preceded by quite a decrease, especially amongst those 20 to 39-year-olds. So again, warrants some significant additional investigation there. Next slide. But regardless, our acute Hep B numbers remain pretty low. So you see the overall counts here from 2013, 38 to 2022, 32. Definitely show, we have reduced burden, but we also know that we don't capture all of the actual cases that occur in the state for many different reasons. But we show this age pyramid here to show some comparison over the decade with age and sex assigned at birth. It's mislabeled here as gender, but it's sex assigned at birth. See similar patterns, a bit of a younger group in 2022, but not too significant given the small numbers here. Next slide. And then race ethnicity, we definitely do see some not so surprising patterns, but those identifying as white, a little bit higher rate than those identifying as Asian Pacific Islander. But the big point here is, especially on the ethnicity side, we're still missing about a quarter, even though we have low numbers here. We try and do our best to really reach all of those patients that we classify as acute Hep B cases, but regardless, we're still left with that 25% unknown ethnicity. Next slide. And then for rates across the state, again, excluding Philly, the rate story here is a bit different than you'll see if we were to show counts here, of course. Allegheny County is somewhat Delaware, definitely have more cases given, more urban centers. But when you look at a rate, you definitely see a rural story play out here. So really kind of varied across the state. Next slide. And then in terms of risk factor information that we receive upon investigation, we don't collect too much risk factor information. We are working to update our questionnaires in our electronic disease surveillance system, but the one that's relatively complete is our injection drug use question. This, as Michaela had mentioned, of course, is a stigmatizing topic, and not everybody wants to answer this question. So we're left with a third unknown, or almost a third unknown here, but about a third reporting yes to recent injection drug use. Next slide. All right, so moving on to chronic Hep B. This also is showing a bit of an increase since 2020, where 2019 to 2020, we saw quite a decrease. So it's an interesting story, again, that we are working to really investigate further. We don't have great national comparisons for chronic Hep B because not every state in the country reports or even requires reporting of chronic Hep B. So we don't have a great comparison here, but some other neighboring states' jurisdictions are seeing similar patterns, but again, that is a stark increase and a higher rate than we saw at our highest point in 2016. Next slide. Again, a story of the 20 to 64-year-olds leading the way here, but the 65 plus also increasing. over the decade. Next slide. So again, this age and sex assigned to birth comparison over the decade does show a little bit of a different picture because the magnitude is different. So we're seeing, again, an increase in 2022 compared to 2013. But the curve generally looks similar on the male side, a bit younger in 2022. Next slide. And then again, our race ethnicity data tried to improve upon it with the match to our immunization registry, but still left with 27% unknown ethnicity and a little bit more unknown race compared to acute disease, but really speaks volumes still about the disparity amongst Asian Pacific Islander identifying folks, and speaks to some of the trends that Michaela had overviewed nationally as well. So not too surprising here. Next slide. And then for our map of rates by county, tells a pretty different story than our acute map did, of course. Different epi trends here driving acute versus chronic disease, but a lot of work to do, of course, in the Southeast, really, led by the charge of the Hepi Foundation and Philadelphia Partners. But lots of work also to do in the central part of the state and in Erie as well, and in the Northeast around Luzerne. Next slide. And then for perinatal B, the reason that I'm not going to dive in too much here is because, knock on wood, luckily we have not seen too much perinatal B in the last couple of years because of the very intensive efforts put into prevention of perinatal hepatitis B in our state. Every state and large jurisdiction is funded to do perinatal hepatitis B prevention. We have an excellent program led by my colleague Sherry Vignier, and really has had some great success in the last couple of years of preventing disease. This is, of course, only through 2022, but we've seen the success continue through this year, and are proud of these numbers. And again, a really collaborative effort to make sure that we prevent this really impactful, costly, terrible condition that can definitely affect infants in terrible ways. So next slide. A bit different way of looking at it, of course, is the exposures to infants. So this really talks to the magnitude of the problem across the state and the work that's put in to prevent perinatal infection. So we see rates per 100,000 births of infants exposed to moms living with chronic hepatitis B. We know that the burden of disease outside of Philly is vastly burdened with this work. But Delaware is also very, very close behind. And our partners throughout the Northeast, you see some of the central counties and even Greene County over there in the Southwest as well, burden when we look at per 100,000 births. Next slide. All right, so just wanted to highlight some limitations here when we're talking about surveillance data. We have to understand that, these case counts do underrepresent true disease burden, especially on the acute side of things, given it's difficult sometimes for us to discern symptoms from other comorbidities, and classifying acute cases can be difficult for that reason, as well as just seeking healthcare for folks affected sometimes can be difficult until, unfortunately, they discover they have chronic disease. So we definitely see, as you noticed, a much higher burden of chronic cases. And we definitely know that those even are undercounted. We want to highlight also that the COVID-19 pandemic led to some underreporting due to competing priorities, obviously. But again, we're seeing that increase post-pandemic that we're investigating. And then acknowledging the missingness of the race ethnicity, especially for those chronic cases. Next slide. So, ultimately we found with this work that, we are experiencing lower hepatitis B rates compared to the national rates, which was great to see. And we know that there are partners across the state, including all of you on the call here, that are working to make this a eliminatable disease. Hepatitis B is vaccine preventable with a very, very effective vaccine. But of those affected in 2022, we did see more males affected, more folks identifying as white affected on the acute side, more folks identifying as Asia Pacific Islander on the chronic side. And then we're seeing, exposures on the perinatal side occurring across the Commonwealth, and speaks to the need to continue our really intensive prevention activities. Next slide. So please, let us know if you have questions. Again, I'm going to put that Philly report in the chat here, but happy to take questions as I went through a lot here. But again, very excited to have the opportunity to share some PA data. Thanks again.
And now we can turn it over to our PA State Health Department Immunization Branch folks. Thank you so much, Lauren, for giving that overview as well.
Can you hear me?
Yes, we can hear you now.
Okay, thank you, Michaela. All right, so good afternoon, everyone. Pennsylvania Immunization Program is funded by the federal government and managed by the Department of Health. It includes initiatives like vaccines for children, school and adult immunizations, and the perinatal hepatitis B program. My name is Sri Parajuli, and I'm the adult immunization coordinator at the health department. And me and my team, we work with providers and stakeholders in Pennsylvania to increase Hep B immunization rates among adults. And in the next 10 minutes, I'll be providing an overview of our program, our efforts, ongoing initiatives, and the future plans around Hep B prevention through vaccination. Next slide. Thank you. So as a program, we work with several providers and collectively refer them as an adult provider network, or 317 providers. It comprises of a select cohort of healthcare providers who are allocated publicly funded adult vaccine that includes hepatitis B vaccine procured through CDC provided Section 317 funds through the state immunization program. At this time, we have a total of 176 providers encompassing FQHC, rural health centers, CMHDs, state health centers, primary health clinics, as well as youth and student health centers. So please note that at this time, participation in this network is only open to providers who are currently enrolled in our Vaccines for Children program and provide services to both pediatric and adult population that is underinsured or uninsured, and that's because of the limited funding. In future, if we get more funding, we'll be opening up to more providers. Next slide, please. So this map exclusively displays the providers who are currently enrolled in our program, the 317 program. And the counties in darker shades have higher rates of uninsured adults, and therefore there are more 317 providers. The one on the southeast, that's dark blue, that's Philadelphia. So all these, Philadelphia has their own vaccine program. So we just cover the rest of the counties. And at this time, through our 317 program, we provide hepatitis B recombinant, and Twinrix, the Hep A and Hep B combo vaccine to providers. Next slide. All right, so we know, we hear this a lot, like the cost of vaccine is a major barrier to many individuals in the United States and also in Pennsylvania. However, there are other several barriers to vaccination. So along with providing free 317 funded hepatitis B vaccines, our program is also involved in various other initiatives and partnerships to address these challenges. And All of these efforts together aim to improve vaccine accessibility and uptake through targeted interventions and collaborative strategies. Next slide. So I'll start with vaccine confidence. So we know the first step in addressing vaccination barriers is to consider vaccine confidence. We know that providers are the most trusted source of vaccine information for patient, and their confidence is very crucial in recommending vaccines to their patient. And since HPV has been historically stigmatized and there is widespread misinformation about the vaccine, we focus on supporting providers by offering facts, peer-reviewed articles, and resources to help them effectively frame conversation with patient about HPV vaccine. And if there's any of you on this call who are within our jurisdictions and have not been receiving these resources from us and would like to have access to these resources and our newsletter, please let us know. I'll be sharing the contact information later. And then we all can agree that importance of monitoring and evaluating data has never been greater. While reporting to IAS is voluntary in Pennsylvania, we do encourage providers to participate in our immunization information system, and we offer training sessions to support enrollment and data submission through bidirectional HL7 messaging. And we consider this a success. In January of last year, we have implemented a fully modernized IAS, also known as PIERS, and it requires all publicly funded vaccinations, including hepatitis B, to be reported by providers. And additionally, following Act 77, the Pharmacy Benefit Reform Act, which was also introduced in 2024, all pharmacists, pharmacy technicians, and interns must enter all vaccination to IAS, regardless of funding source of vaccine. So this expanded access to vaccination data has enabled us to analyze coverage rate, forecasting the trend, studies by counties, and peer-enrolled sites are able to estimate their hepatitis B vaccine coverage by first, second, and third doses, identifying missing doses, and use that data to improve clinic workflow based on those findings. Next slide. So to support health systems in implementing universal Hep B recommendations, we regularly share nationally available webinars, resources, and tested quality improvement programs with providers. And this webinar is one of them. Our part 2 of this webinar will be mostly focusing on implementing those recommendations at a provider or a clinic setting. Next slide. So to boost adult immunization rates by engaging managed care organizations, there have been some steps taken to aid immunization rates for flu and COVID to Medicaid's quality reporting programs. And this kind of QI measures, we hope will increase the rates of other adult vaccines as well, and that includes hepatitis B. Next slide. And we are glad to share that the leadership from the Health Department and Department of Human Services, they both recognize the return on investment for all adult vaccines, and they continue to advocate for increased funding for immunization programs with policymakers. And specifically for Hep B prevention, they collaborate with Hep Free PA Coalition to engage the MCOs and address insurance and payer challenges. Next slide. So we do offer free vaccines to our enrolled providers, but also from time to time, our state health centers and immunization program field nurses, they collaborate with local immunization coalition and community organizations to deliver hepatitis B vaccine through off-site clinics during respiratory virus season. And most of those clinics are walk-in and some are even held on weekends. Next. And as a program, we are planning to assess and support the implementation of adult immunization standards across specialty providers by evaluating their current practices, identifying gaps, and providing targeted resources and training to improve patient adherence and outcomes. And that includes the rates for hepatitis B vaccination. Next. And additionally, through a partnership with PA Cancer Coalition, their HPV work group, we promote Hep B vaccine as a key tool for cancer prevention and have been working and creating resources for public awareness. Next. So despite low funding historically for adult immunization, we actively pursue cross-program funding opportunities within the health department to meet the needs of uninsured and underinsured people. And that's something we'll continue to do. So this, all of these blocks, they provided a high-level overview of our efforts in Hep B prevention. And then we do realize that while we'll be continuing these efforts, there are also several areas for improvement. So we welcome your feedback and input to improve our program's impact. And with that, next slide. Thank you. And like I said before, if you want to reach out to your program or have any questions or have any comments or feedback, then or want to be included in our distribution list, please send us an email. You can see the email address on the slide. And I think next I'll hand the mic over to Michaela. Thank you.
Thank you so much. Really appreciate that. And with that, I think we can move into the PA Q&A portion of this webinar. So if anybody has any questions, please feel free to drop them in the Q&A box. I know somebody was wondering if the slides would be available, and yes, we will be sharing the slides as well as the recording after the webinar. You can also raise your hand on this webinar if you'd rather ask a question verbally as well. So I can kick it off by asking our panelists, since you all work for the state health department, and I know some of the people on these calls might be members of community groups or others who kind of work outside of that government space, and they're always wondering about specific ways to collaborate. Do you have any advice to those who might be looking for ways to promote vaccination and or screening alongside the health department?
That's Lauren. We have an organization that some of you may be aware of called the Hep-Free PA sort of advocacy group devoted to the elimination of our hepatitis statewide. And I'll put the website that we have in the chat. If you're interested in joining that group, I'll also put my email in the chat. Let us know if you'd like to join that listserv. We try and really supports the group as state employees as best we can, but it is externally led by community advocates across the state, and are always looking for new members and folks, enthusiastic about eliminating viral hepatitis in Pennsylvania.
Thanks so much, Lauren. And Sharia, Desiree, do you guys have any thoughts?
I think Lauren provided a great overview.
Great. So we have another question. Can you share how we are currently working on addressing misinformation related to hepatitis B vaccination specifically? So I can start from the Hepatitis B Foundation's perspective, and then I can turn it over to the immunization branch potentially, as I'm sure they have a few thoughts. But I think from the community perspective, misinformation obviously is a very, very big deal, but a lot of it does come from a lack of education, and that's from all sources, right? So I think a lot of people probably haven't heard about hepatitis B, let alone really realize that they might have been vaccinated for it earlier in life, or that they might not have been vaccinated for it given their age. A lot of people just kind of assume that they've been vaccinated because, oh, I get all my vaccines, right? So I think for us, having a conversation, just a candid conversation, and letting them know what hepatitis B is from the start and its consequences has been incredibly important to addressing a lot of misinformation. One of the messages that we always drive home is that hepatitis B vaccination is liver cancer prevention. A lot of people have no idea what it causes or what not being vaccinated can actually lead to. And so they don't really think about it. And it's kind of very easy to believe a lot of the misinformation around the vaccine at that. I will say in the adult space, we haven't heard a lot of misinformation, just a lot of lack of understanding about the virus itself. It's a little bit different if we shift our view down to kind of the pediatric and baby space, I will say. And I know this is an adult webinar, but I think this kind of carries through the message of hepatitis B misinformation in general. And a lot of it is that, oh, hepatitis B is only sexually transmitted. Hepatitis B can only be spread through drug use. And a child doesn't need hepatitis B vaccination because it really won't do anything or it won't matter if they get it. Well, we do know it matters because they will lead to chronic hepatitis B, right? A 90% chance of chronic hepatitis B if they're infected as children. The sexual transmission, I think a lot of people just don't understand the mother to child transmission portion, or the fact that before the age of 10, nearly 20,000 um, children in the United States were being infected and we don't know how. So really working on the education around hepatitis B vaccination across the lifespan has been incredibly important to helping combat that misinformation. And we're educating providers, we're educating the public, we're educating anybody who has any sort of stake in the immunization space so that all of the messaging is really consistent and we're all on the same page with the information. Does anybody else have any thoughts on how we can address or how we are addressing misinformation with the hepatitis B vaccine specifically?
I think I think I'll just add to what you had to say, even though this is an adult one, and kind of reinforce what Dr. Orcas has said about our perinatal hepatitis B program. One of the keys factors that makes that program so successful to keep those numbers low is a constant sharing out of information with the birthing hospitals um, around hepatitis B and the importance of the vaccination and what the causes could end up being for a baby that is not vaccinated. And it's constant, sharing of any new updates from CDC with those populations. So I would say that's definitely one, at least for the birth dose of Hep B. And then Sri, I don't know if Sri has anything else to add, but again, I'd probably, mimic what you said, Michaela, about it is about education and continuing to get that information out and keeping, our providers and those that we're working with updated and aware of, what's new and what's important regarding hepatitis B.
Thanks.
Thanks,
So we have
Desiree. So Michaela, I wanted to add a few points as well. And I think right now in today's world, we hear a lot about vaccine safety. And a lot of times, lack of knowledge about vaccine safety can lead to vaccine hesitancy. So we do think that providers and the community workers who are working in the immunization space, so one way they can help is just talking to people about how vaccines are developed and how the safety and monitoring is evaluated by CDC and the FDA, and also highlighting the silent progression of hepatitis B and the long incubation period, and then when you can be asymptomatic and and not actually have not actually know that you have hepatitis B. I think those kind of conversations really highlight the importance of preventative aspect of this vaccine. And also one other, I would say it's a myth, not a misconception, that hepatitis B vaccines are only necessary for healthcare workers or people who use like drug, and overlooking the risk of sexual transmission. So I think it's important for us and the providers and the advocates to emphasize these facts and dispel the myths about vaccine additives, like the non-existent mercury. I think that's also very crucial for building trust and improving uptake of vaccine.
Thanks so much. And we actually have a couple of questions about funding for vaccination, which I think are really great to address. So, the first one is, do you have any concerns about federal sources for the VFC program being eliminated? And have you realized any cutbacks at the state level for vaccine programmings and staff for now, or do you anticipate any in the future?
So I'll try to answer that one. We, as far as I know, at least from a management perspective, I have not heard of any potential cuts to the VFC funding. But unfortunately, with the political environment the way that it is right now, it's unknown what will happen in the future. So we continue to just move on like we would. We did just get our notice of funding for our immunization programs from CDC, so that's always a good thing. So we have funding for this year. But obviously, if there would be something that would come down the pike regarding that, I'm sure it's something that we would address at that point. And as far as a state level cutbacks, unfortunately, I think Surya mentioned it, we have no funding from no state funding for immunizations at this point. So most staff that work in the Bureau of Immunization are funded with federal funds, not state funds. So our leadership continues to encourage and ask for state funding for immunizations. But at this point in time, we have not gotten any funding. So we'll keep trying. I know that they'll keep trying for that and see how that moves forward. So.
Thank you so much. So I'll ask one last funding related question, and I think we have a couple epi questions as well. So the question is, will we be able to order more Hep B vaccines from 317 to meet the demand if needed? I think we're talking about the updated recommendation and how it's expanded. So will they be able to order more Hep B vaccination from 317?
Yeah, I can take that. So first of all, it depends on whether you are an enrolled provider. Like I mentioned earlier, if you are already a provider who is enrolled in our 317 program, then yes. And then even though we have some ordering caps, if there is a need, we try to fulfill the demand. But if you are not enrolled in our program, you can send us an email and we'll get in touch with you and we can discuss about it further.
Thanks. And so, Lauren, I think this might be a great question for you. So should people who don't obtain Hep B immunity from the childhood series get immunized again? If so, should they get immunized if they do not have immunity the second time? So it sounds like a potential non-responder.
Yeah. So we actually don't have the clearest advice here. I think we can definitely circle back to our clinical team and Epi to suss this out. But another vaccine's never going to hurt. But I have heard from clinicians that sometimes
I can also chime, thank you so much, Lauren. I can also chime in and say that we do have some information on our website that I'll be happy to drop in the chat about non-responder situations. Oftentimes, like Lauren said, it is kind of on the clinical level, but switching to different vaccines, if one vaccine did not work for you, sometimes people might see a response then. So there are a couple of different options to potentially try as well. So we'll definitely make sure to share that information with you.
Thanks, Kim.
Of course. So, sorry, I'm just scrolling through the questions. There is another question. If you had the pediatric Hep B series with the new universal parameters around the adults, should adults get a repeat hepatitis B vaccination series?
So that's assuming that they completed the series in childhood completely. Can I clarify that if somebody wants to add that to the chat? So if they, go ahead, I'm sorry.
No, please go ahead.
Yeah, I guess if you can verify that they did complete the series, if there's question of that and you're able to confirm, then they would be considered vaccinated. But if there's any question, from our perspective in Epi, I mean, another vaccine is never going to hurt. We always really lean on our immunization colleagues, as I know the 317 vaccine is extremely cultivated and protected, but we do encourage additional vaccination if full vaccine series is unclear. Go ahead, Catherine.
Yeah, just to build off of what Lauren was saying, I think checking for immunity, oftentimes this is something that might be required for school. For example, we see this a lot. An hepatitis B surface antibody check would be great before starting a new additional vaccination series, just to see where the person is in terms of protection. If the antibodies are at 10 international units per milliliter or greater, that would indicate protection against hepatitis B. And so therefore another vaccination dose or series would not be needed in that case. But again, if it's less than that, then you would want to vaccinate again.
Thank you guys so much. And yes, they did clarify that they had been fully vaccinated, so the 3-dose series as a child. And I think we have an attendee who is raising their hand, so I can take you off of mute, Catherine. Hey, Catherine, Jay, can you hear us? Do you still have a question?
No, I'm good. I'm sorry. That was my question before that you raised, that you answered. So thank you. I decided to type it instead. Thanks.
Of course, no worries.
Okay.
All right. So there's another question about a non-responder. It says we have been given instructions that if a person is a non-responder, we should repeat the vaccine and test for hepatitis B surface antibody and hepatitis B surface antigen. So yes, that kind of alludes to what I was referring to earlier. Oftentimes it's not enough to declare somebody an official non-responder with just one vaccine series. So typically, I believe the protocol is to vaccinate them again, oftentimes using a different vaccine than the first one to see if that might help, and then to test them to see if they responded to those. Although, as Catherine mentioned, using the triple panel is really important to make sure, because sometimes people are vaccinated without even knowing that they have hepatitis B. And that could be potential reason why people are not responding to the vaccine. Well, it's because they already are living with the virus. So a couple of different ways to do that. And I believe somebody might have dropped in the chat a couple of non-responder information facts as well. So we'll definitely be sure to share those resources with you all after the webinar. And there's a question, is there still a CDC limitation for 2 series in a lifetime? I am not entirely sure of that. Sri or Desiree, are you guys familiar with that limitation?
I am dropping the link to the most recent CDC's recommendation for hepatitis B vaccine in the chat.
Okay, thank you.
Yeah.
And that
And yeah, we have different vaccines available. Like there are 2 vaccine which for which you need 2 doses to complete the series, and then you have a vaccine for which you need 3 doses to complete the series. And one thing to really keep in mind is, you know, if you begin your vaccination series with one brand of hepatitis B vaccine, and then the other brand is not available, CDC says that the series may be completed by using a different brand. And whenever it's feasible, you should try to use the same manufacturer's vaccine to complete the series. But protection is more important. So, vaccination should not be deferred when you don't have the same vaccine available. And then this also really highlights the point of providers reminding their patient to come back for the second dose and setting up appointment for the second dose before the patient leaves the office after they're receiving their first dose. We are seeing some gap between the coverage of first, second, and third doses of hepatitis B, and being aware about this fact and also sharing this with patient is really important, so that we minimize that gap.
Thank you so much. And if the person who is on the phone can just drop their question in the chat, that would be great. And we only have around 2 more minutes. So I would love to give our panelists an opportunity to share any final takeaways or points that they think might be most important to share with this audience about hepatitis B vaccination, the epidemiology and PA, or any of the work that the immunization branch is doing.
I can go first from an epi perspective. Again, really excited to share these data with you. If you're interested and have any more questions, let me know. Again, if you're interested in sort of the advocacy side, specifically in Pennsylvania, please reach out to join our listserv for Hep Free PA, and Hep B Foundation has some wonderful opportunities for advocacy as well. So please, let us know if you have additional questions. These questions have been really fabulous to work through. So thank you for the attendance and participation here.
Great. And Surya, is there anything you want to share? Final takeaways?
Yeah, this is Shri. So I want to really highlight that even though we are a state immunization program and we do offer 317 vaccines to uninsured and underinsured, when it comes to provider, we work with all providers. They don't necessarily have to be in our provider network to receive, access to resources or have access to trainings of our IIS and be part of our distribution list. So please do not hesitate to reach out to us, and we're all in this together. Thank you. And thank you for everything you do.
Thank you so much. So before we close out, I just wanted to share that we will be back same time, same day next week. So Tuesday, July 22nd at 2 p.m. To talk more about the implementation of the universal screening and vaccination guidelines that we discussed. Especially how to potentially integrate it into an EHR system and how providers can better speak with their patients and encourage uptake of adult vaccination. We'll be joined by Dr. Cami Graham and Dr. Myra Rutland to share their perspectives of working in PA and working in a large health system. So please do join us. It will be the same exact link as the one you used today. We'll send out a reminder. But thank you all for your time. Thank you all to our wonderful presenters for sharing your expertise. And I hope you guys have a great rest of your day.